Hey everyone, my name is McKinzie Gales. I have a master's in public health degree and roughly 7 years of experience working in the public health and global health field. Today, I will be presenting on the case for collecting, analyzing, and using sex disaggregated data and gender data for outbreak response, a systematic literature review from 2012 to 2022. This is the first phase of a larger multi-agency phased project, which is the Sex and Gender Equity in Research, SAGER for Integrated Outbreak Analytics IOA project. So I'm just going to share my screen. Okay, so while I work for the Centers for Disease Control and Prevention, or CDC, in the United States, this is a multi-agency project and is being guided by an advisory group of key partners from the agencies listed on this slide. Over the next 20 minutes, I will review the SAGER IOA project and briefly describe what Integrated Outbreak Analytics, or IOA, is. I'll define sex disaggregated data and gender data, and then I'll present on phase one of the SAGER IOA project, which is the systematic literature review. The SAGER IOA Guidelines project emerged from the growing recognition in the literature and in the field that the inclusion of sex disaggregated data and gender data is critical to controlling transmission and delivering an effective response. Over the years, recommendations and minimum requirement guidelines have been developed. One example is the Sex and Gender Equity in Research, or SAGER guidelines, and these were developed to provide researchers with a framework for incorporating sex and gender in their manuscripts. Additionally, these guidelines encouraged editors to facilitate the integration and evaluation of sex and gender in the submitted manuscripts. However, despite the available guidance, there remain significant gaps in the availability of these data, particularly during outbreaks and public health emergencies. In 2021, the Analytics for Outbreaks Working Group within the Global Outbreak Alert and Response Network, GORN, identified the need to adapt the SAGER guidelines for operational integrated outbreak analytics. So what is integrated outbreak analytics? Integrated Outbreak Analytics, or IOA, is an approach to outbreak response and was first developed in 2018 during the Ebola outbreak in Eastern Democratic Republic of the Congo. IOA uses multidisciplinary data, which includes programmatic, surveillance, healthcare perceptions and behaviors data, and more to better understand outbreak dynamics and inform context-specific operational decision-making. The integrated outbreak analytic approach helps outbreak response actors understand why a disease occurs in a particular location at a particular point in time, and how this disease, as well as response activities, affect communities. Since 2020, IOA has been used to understand outbreak dynamics in many different public health emergencies and to inform emergency or outbreak responses with multiple partners. For those who are interested, the link on the slide will bring you to a YouTube video that provides a more in-depth description of IOA. The YouTube channel URL will also be displayed on the last slide of this presentation. So sex disaggregated data and gender data are key and required pieces of integrated outbreak analytics and the teams implementing this approach. Thus, the SAGER IOA project aims to facilitate the adaptation of the SAGER guidelines to provide clear, concrete guidance for collecting, analyzing, and using sex disaggregated data and gender data for outbreak response. We are hopeful that these guidelines will lead to better understanding of outbreak dynamics and allow for more appropriate and gender transformative responses. For the SAGER IOA Guidelines project, we are taking a multi-phase participatory approach. Phase one is the systematic literature review, which will be the primary subject of this presentation. Phase two includes consultations and workshops with actors working in outbreak and public health emergency responses. The purpose of phase two is to gain insight into the challenges and opportunities related to the collection, analysis, and use of sex disaggregated data and gender data during outbreaks. Phase three will be the drafting of the SAGER IOA guidelines using the data collected in examples that were co-developed in phase two. And phase four will be pilot testing the guidelines in various outbreak contexts and revising as we need. Before we go any further, it's important for me to define sex disaggregated data and gender data. So, sex refers to biological characteristics such as chromosomes, reproductive organs, and sex hormone concentrations, which vary among intersex individuals, females, and males. Physiological and anatomical differences between sexes can have an impact on the body's ability to regulate and eliminate pathogens, as well as it influences exposure and transmission. Sex disaggregated data means that at the very least, female and male sex data is collected and analyzed separately. For example, disaggregating dengue symptoms by sex allows us to identify vaginal bleeding as a potential symptom for those with female anatomy. However, frequency of vaginal bleeding among female patients with dengue is rarely reported in scientific literature, and this is because it's oftentimes categorized as hemorrhage and symptom profiles are not disaggregated. Understanding the symptom differences between sexes can allow for more effective public health communications, diagnosis, and treatment. Gender refers to the socially and culturally constructed characteristics of men, women, and non-binary individuals, which are attributed to a specific culture and context and can change over time. Gender is usually conceptualized in research as binary, though there is a spectrum of identities and expressions that will shape a person's potential comorbidities, exposure, healthcare-seeking behaviors, treatment options, and more. Gender data reflects the sociocultural differences in the situations of women and men. These include gender norms associated with education, occupation, and health-seeking behaviors, all of which can influence differential exposure to pathogens and access to prevention and treatment. An example of gender data is the differences in exposure to Ebola. Men are more likely to be exposed to Ebola through direct contact with infected bushmeat, whereas women are more likely to be exposed to Ebola and are at higher risk of contracting Ebola due to caregiving roles in families and societies. Knowing this can allow for more effective prevention, diagnosis, and even treatment interventions. Okay, so phase one. The keys for collecting, analyzing, and using sex disaggregated data and gender data to inform outbreak response, a systematic literature review from 2012 to 2022. This systematic literature review has three objectives. The first is to document and analyze evidence of sex, gender, and or pregnancy data during outbreaks. The second is to understand outbreak dynamics and considerations for preparing more appropriate and gender transformative responses. And the third is to describe current gaps in sex disaggregated data and gender data collection, analysis, and use in outbreak analytics and responses. In adherence to the PRISMA guidelines, which provide a minimum set of evidence-based items for reporting and systematic reviews, we formulated our approach for the systematic literature review. Our process started with developing and implementing a search strategy. Subsequently, we established our inclusion and exclusion criteria. The literature obtained through the search strategy was compiled, deduplicated, and imported into Covidence, which is a web-based software designed for screening and data extraction. The titles and abstracts were of all identified literature were screened to assess their relevance. Those meeting the criteria underwent a full text review. To ensure accuracy, two researchers independently conducted these reviews, resolving any conflicts through consensus. Articles satisfying the inclusion criteria were then categorized for data extraction. Additionally, we conducted a backward citation search where the reference lists of included articles were reviewed to identify any potentially missed articles from the initial search. Newly identified articles from the reference lists underwent the same screening process. 5 databases were searched for peer-reviewed articles examining sex, gender, or pregnancy-specific outcomes for communicable disease outbreaks published in English between January 1st, 2012 and April 12th, 2022. Our population of interest were human subjects residing in low and middle income countries. We used the World Bank 2022 definition of low and middle income countries and excluded China due to the country's capacity for health emergency, humanitarian crisis, and outbreak response. Disease outbreaks cited by the International Health Regulations Declaration of Public Health Emergencies of International Concern and the SPHERE standards were included. COVID-19 and tuberculosis were excluded due to the extensive gender research already being conducted on these diseases. Our search strategy produced 15,327 unique articles. 15,287 were eliminated during the abstract title and full text review process. Through a backward citation search of the 40 remaining articles, an additional 386 articles were reviewed and 31 articles were included. As a result, a total of 71 papers met the inclusion criteria and were analyzed. Of the 71 articles, the majority reported on either Ebola, Zika, or both. 33 of the 71 articles reported outbreaks in Brazil, and 11 articles reported outbreaks in Sierra Leone. These were the top 2 countries cited in the literature. For our analysis, we used an adapted version of the World Health Organization's gender analysis matrix, looking at how sex, gender, and pregnancy status interact with risk factors and vulnerability, access and use of services, health and healthcare seeking behaviors, prevention, detection, treatment, and management and recovery options, experiences in healthcare or with services, and health and social outcomes and consequences. We chose to separate out pregnancy status as it has both biological and sociocultural aspects that impact outbreak dynamics. We then applied this adapted matrix across the outbreak response timeline, which is prevention, detection, treatment, and management, and recovery. Starting with prevention, we mapped the available evidence from the literature for sex, gender, and pregnancy-related dynamics. In the interest of time, I'll only give a couple of examples for each phase of the outbreak timeline: prevention, detection, treatment, management, and recovery. An example of a sex-mediated risk factor is evidence in the case of Zika. The presence of infectious Zika virus has been detected in semen for up to 62 days after onset, contributing to higher rates of male to female sexual transmission. It's important to note that research did not specifically investigate trans or intersex individuals. However, based on the available evidence, we can infer that individuals with internal genitals who engage in sexual relations with people possessing external genitals are at an elevated risk of Zika exposure through sexual transmission. Zika prevention response efforts interact with traditional gender roles and place women in a double bind by expecting them to prevent pregnancy and Zika without addressing the gendered power dynamics hindering them from doing so. Women were responsible for vector control activities and preventing pregnancy. However, research among women found that enforcing condom use with a stable partner was challenging, and women feared endangering their relationship and their safety. Additionally, Zika prevention messaging about sexual transmission and pregnancy did not target men. Research on Zika reported poor healthcare experiences for pregnant individuals. Healthcare providers in some locations purposefully did not discuss abortion options with pregnant patients, even after ultrasounds identified fetal abnormalities and these services being available. The matrix was also used to analyze evidence for sex, gender, and pregnancy-related detection differences. Sex-related diagnostic options are available for diseases such as Ebola. While Ebola RNA can be detected in both semen and vaginal fluid, it is more frequently detected in semen. This discrepancy in detection rates may be attributed to variances in viral shedding patterns or the sensitivity of the testing methods employed. And it is important to note that the detection of a virus does not automatically signify active infection or disease transmission. Gendered patterns of healthcare seeking have an impact on the dynamics of disease outbreaks and what we know about them. For example, in various Asian communities, women frequently rely on traditional practitioners who are not linked to public health surveillance systems. As a result, the lower reported incidence of dengue fever among women may be a statistical artifact caused by insufficient detection and surveillance methods. During pregnancy, individuals face a risk of being underdiagnosed or misdiagnosed due to the phenomenon of pregnancy masking symptoms. This has been observed in cases of dengue where the clinical manifestations of the disease can be mistaken for physiological changes occurring during pregnancy, thus complicating the diagnostic process for physicians. Next, we employed the matrix to analyze evidence pertaining to treatment and management. I'll present a couple of examples related to Ebola, and there was no evidence of sex-mediated differences for treatment and management in the literature. Research examining gendered treatment-seeking behaviors during Ebola outbreaks revealed that women experience limited mobility in conflict-ridden areas with heightened insecurity, and this resulted in reduced access to healthcare. This was primarily due to gender-based violence, attacks on health facilities, and healthcare workers. Pregnant individuals experienced delayed treatment of Ebola. Two studies discussed the impacts of pregnant individuals being denied maternal obstetric care until a negative blood test, which resulted in vesicovaginal fistula, intrauterine fetal death, and maternal death. Finally, evidence for recovery-related dynamics were analyzed. During the recovery phase, studies have identified a significant risk factor indicating the presence of Ebola and Zika RNA in semen post-recovery. This finding highlights the prolonged potential for sexual transmission of the virus. During and after Ebola outbreaks, women are likely to experience health and social consequences. Research indicates that women are more susceptible to economic loss, as they are more likely to be in less secure employment or to work in sectors of the economy impacted by quarantine interventions. And Ebola outbreaks have significant consequences, as highlighted by a study that looked at Guinea, Liberia, and Sierra Leone. An estimated 4,022 women would die annually during childbirth, and these deaths are attributed to the loss of healthcare workers in these countries due to Ebola-related fatalities and the subsequent disruption of maternal and child health services. I hope that these few rapid examples helped illustrate the importance of collecting, analyzing, and using sex-disaggregated data and gender data to inform outbreak response. The results of this review showed that sex, gender, and pregnancy affect outbreak dynamics. Understanding and considering sex, gender, and pregnancy is important at every stage in the outbreak response timeline. So some key takeaways are that while sex data is often collected during outbreaks, there is a lack of research that reports disaggregated outcomes by sex or explores gendered roles. Also, the interchangeable use of the terms sex and gender hinders our understanding of the underlying causes of observed differences. And neglecting to collect, analyze, and use sex disaggregated data and gender data during outbreak responses leads to incomplete information, less effective responses, and negative health outcomes. The evidence from this review emphasizes the need for an inclusive approach to outbreak prevention, detection, response, and recovery that considers sex and gender specificities. So our next steps for the SAGER IOA project include submitting and publishing the systematic literature review manuscript in an academic journal, conducting participatory consultations and workshops with outbreak actors, co-developing the SAGER IOA guidelines, and piloting and revising the guidelines. So thank you so much for this, for your time. It's been a pleasure to present this multi-agency project. Please feel free to email me with any questions. And the link here will bring you to the YouTube Integrated Outbreak Analytics channel if you're interested in learning more about this approach.